I'll be talking about a new indication for endoillumination assisted scleral buckling in a failed VR surgery. There are multiple literatures that talks about surgical outcomes of pars plana vitrectomy versus scleral buckling for primary rhegmatogenous retinal detachment and surgical outcomes of vitrectomy in a failed scleral buckling surgery. Endoillumination assisted scleral buckling combines the advantage of both scleral buckling and pars plana vitrectomy as it's an external approach and gives a better visualization. Repeat intraocular manipulations in an already vitrectomized eye carries its own set of risks and complications and difficulties. By combining the technology of endoillumination to scleral buckling procedure in form of EASB, can a simple, equally effective extraocular old procedure come to the rescue of a failed modern vitreoretinal surgery? No published reports exist as of today about the surgical outcomes of EASB in silicon oil-filled eyes with failed vitreoretinal surgeries that presents with retinal redetachment. So my aim is to evaluate the surgical outcome of endoillumination assisted scleral buckling in eyes with failed vitreoretinal surgeries. It's a prospective interventional case series operated by single surgeon for 6 months duration on 25 eyes of 25 patients. All the patients underwent non-drainage endoilluminator assisted scleral buckling and were followed up to 3 months. The inclusion criteria were retinal redetachment after vitreoretinal surgery, silicon oil-filled eyes, no visible break, and PVR less than C2. The exclusion criteria were history of use of encircling band, silicon tires, and history of use of gas tamponade, posterior causative breaks, and pre-existing glaucoma or media opacity. Here is the surgical representation. After doing a 360-degree peritomy and muscle breedling, 25 gauge endoillumination 25 gauge trocar cannula was inserted, and by endoillumination all the breaks were visualized and cryopexy was done of all the breaks. After that, the scleral buckle along with encircling band was passed. The peritomy was closed. So now let's come to results. 40% patients were female, 60% were male, 65% patients were phakic, and 35% patients were pseudophakic. The median age group was 48 years. One patient had one fixed fold and one patient had a posterior break found intraoperatively that was converted to vitrectomy. One patient had significant lenticular opacity, so that precluded the break visualization, and the patient was converted to combined phaco with repeat vitreoretinal surgery. The retina was attached on day 1 in almost 91% of cases. The best corrected visual acuity improved significantly at first month and was maintained at third post-operative month. Intraocular pressure, there was no significant change pre-operatively versus first and third post-operative month. There was no significant change in silicon oil meniscus post-surgery, and no patient developed endoilluminator site-related break or cataract at third month follow-up. This is the pre-operative and post-operative picture. So EASB enables an extraocular procedure with ease by circumventing the difficulties of visualization due to small pupil, posterior capsular opacification, silicon oil meniscus, retinal holes in myopic eyes, peripheral small breaks in pseudophakic eyes. So by virtue of being majorly an extraocular procedure, it circumvents the intraoperative challenges such as making retinotomy and iatrogenic breaks. So it's a safer choice in patients with high myopia with vitreous schisis, where attempt at PVD can cause further retinal damage. In one-eyed patients, history of keratoplasty, aphakics, and unstable IOL. The possible rate limiting factors in our patients were trained assistant for holding a contact wide angle, interfering blood meniscus, optical hindrance caused by silicon oil meniscus upon indentation, small sample size, and we were only doing non-drainage surgeries. So the take-home message is, endoillumination assisted scleral buckling obviates further intraocular manipulations and its associated complications in an already vitrectomized eyes. It's a safer choice than a repeat intraocular procedure. in eyes where a considerable anterior break is the cause for retinal redetachment. Despite limited sample size, the success rates are encouraging enough for it to be considered as a standard protocol in selected cases. These are my references. Thank you.
So in a vitrectomized eyes, didn't you find difficulty in passing the buccal after in the second stage?
Ma'am, I could not hear you.
In the vitrectomized eyes, didn't you find difficulty in passing a
Ma'am,
buccal?
they were all oil-filled eyes. We closed the port after the endoillumination, so it was okay. There was no much problem.
Someone must be leaking from the port you have created with endoilluminator.
No, ma'am, we sutured it, so it was not leaking.
So it's rather other way around, like now we are doing buckling after the vitrectomy.
Yes,
This is what, yeah.